LAMA2 care. My name is Rotem Orbach. I work with Dr. Foley and Dr. Bonneman at the NIH, the Neuromuscular and Neurogenetic Disorders of Childhood section. And I'm very privileged to moderate today's session. My only job is to keep us on time. I already failed because I think it's 2:15, right? But we're gonna have lots of time also to chat after the session, so please feel free to reach out at any point during the meeting to talk to us. And we can introduce ourselves.
Stand on the other side, okay, sure. I'm Reghan Foley. I'm a pediatric neurologist, neuromuscular specialist. I work at the National Institutes of Health.
I'm Clara. I'm also a pediatric neurologist. I work in the University of São Paulo in Brazil.
I'm John Pascoe. I'm a pediatric pulmonologist with a sleep background too at Cincy Children's.
I'm Ian Conley, child neurologist and neuromuscular doctor at Nationwide Children's Hospital.
I'm Megan Iamarrino. I'm a neuromuscular physical therapist, and I was for many years working with Anne at Nationwide Children's, but I'm now at University of Texas Health, San Antonio.
We have another slide with some topics for today, but also we encourage really an open discussion and questions. So if anyone would want to start. Okay, so we have a long list here on the slide, but we don't have to follow that. And I think because that's the opportunity for you to ask us questions, maybe we start with that and then try to address everything that's on the list, on the agenda that Rachel kindly put for us. So anyone in the audience would like to start with a clinical question or other question?
I mean, I have the mic, I'll start, which, by the way, I have the mic, I can run it around if anyone has questions. Our son, James, 7, he'll be 8 in November, LAMA2, obviously, had scoliosis corrective surgery last year. It was actually this time last year we brought him home. His magic rod's put in, obviously still growing. We go to the University of Rochester every 3 or 4 months, high-end, and get the rods lengthened. Obviously, he's continuing to grow. We recognize that at some point in the relative near future, we're going to have to look at, depending on his skeletal maturity and how that goes, we'll have to look at spinal fusion or some sort of bridge between where he is now and a more permanent spinal fusion surgery. And I guess I'm just interested in the group's thoughts on that transition. Obviously, all of these kids, these individuals are different and they're on their own path. I personally feel that 7 was, or 6 was a little bit early for this surgery. That could be just anecdotal based on my own thoughts there, but just interested in the group's thoughts on where he is, the transition to where we are likely going to have to be in a few years, and then, thoughts on prehabilitation, rehabilitation, sort of how we prepare for that, and just general thoughts.
Thanks. Yeah, so perfect topic to start off the discussion. So one of our adult patients with LAMA2 leg dystrophy who's was at an European Neuromuscular Center conference we were at in January spoke about really it'd be helpful for parents to know kind of in terms of periods of life, what's expected, what's going to be coming down the road, how to prepare for that. You're right, it's a little early, age 6. The data that I kind of had shared out of London is a little bit later, but they gauge off of the rigidity. If the curvature gets a little bit rigid, we talk a lot with the orthopedic surgeons, and they say if it gets a little bit rigid, they want to make sure they get something in place like magic rods to promote growth, but also to stabilize, the spine as it's growing. So that's was right timing. It was a careful approach too. They made sure that the gastrostomy tube was in place first. It's always a huge part of the healing process to have good nutrition on board. And so it's the degree of the curvature, it's the rigidity of the spine, it's the pulmonary function at the time. We've seen the reverse problem more commonly, which is people or care teams like this adult patient that we know very well, who in Boston Children's Hospital years ago, who waited too long, and then it was too late to even correct the spine. So early is okay if it's adjustable like magic rods. I guess your question's more of to the ultimate fusion time or the rehab.
Yeah, and just based on the clinical experience, the anecdotal experience, all the observations you've had, you know, the magic rods have a certain shelf life, so to speak, right? Those aren't going to be in forever. Eventually, I'm assuming it's mechanical in nature. It'll break down just like most mechanics do. Again, this could be different. Is that a 3-year window? Is that a 5-year window? What should Molly and I, my wife and I, be looking for and get ready for as to understand when we need to start talking about what comes next? And by the way, we have a fantastic team. Dr. Susan Nelson, the orthopedic surgeon in Rochester. Emma Cefaloni's neuromuscular clinic is fantastic, right? So we're well taken care of there, but obviously want to take advantage of the time here with you all.
So I've spoken with a couple surgeons in the past month for the same exact question. When's the time to go for the final fusion? They wait as long as possible, growth perspective. It depends also on the degree of axial weakness, that weakness of that neck, extension and axial weakness. So if the current rods have too much kind of pull and torsion on them, and they find that the curve is still progressing with the current rods, then they may have to go earlier than they predict. But it's an ongoing conversation, ideally with the neuromuscular team, with the pulmonology team as well. I don't know if anyone wants to add anything further.
I'm not an orthopedics, but still, I'd like to add that prior to 10 years, I don't think that nobody's comfortable with doing the correction, the permanent correction. So at least prior to that, we try to avoid it. And also that's really important, I'm sure that you know that, but I would like to add, to check the bone health, because that's really relatable to the success afterwards of the surgery, and to check if the fusions are going to be in the right place, because if the bone is not healthy enough, then the chances are that you're not going to be able to maintain the fusion in the right place, because then the bone it's not that strong, and then maybe it's going to miss the place and start having pain, and so that's really important. But from what I know, prior to 10 years, it's not a good timing.
For the final fusion.
Yeah.
Yeah, and I think the rigidity and the flexibility of the curve is a really important point too. And in terms of guiding the management, again, not ortho, but definitely we interact a fair bit with ortho from the pulmonary standpoint. Clearly, obviously, I will say that I think it's fine. I think every scenario is a little bit different, right? So. I think that the ortho groups are thinking less about growing constructs, being the magic rods and whatnot these days, just because there are, hopefully everything's good and won't have complications clearly, but there can be a fair number, unfortunately. And with even though it's a non-invasive lengthening, it's sort of, in the past, you'd have to do a quick procedure to try to lengthen the rod. But in the end, it sounds like there's still potentially a fair amount of complications that still you end up going back to the OR anyways. But in terms of the final fusion, I think there's a big push now to just try to wait for even growing constructs and see how far you can get before maybe just doing the definitive fusion. And growth obviously is very important, and they're always checking the bone age on films and such. But if you have to think about being able to help your son or daughter as they get older, and being able to pick them up and move them or help, in any way possible. And so, if you're a full adult size, it can be much difficult with that. The other thing I'd like to add is we're focused on the chest and the lumbar area a lot, right? But we also need to think about the cervical neck. And that can be an oversight. So for some where their neck is back like this, if that gets tight, if you only address what's down below, all of a sudden you're sitting straight up and you're doing this because you can't move. And so you need to have, and most of the ortho docs are very sensitive to this now too. But addressing sort of the cervical area and being able to safely extubate as well is huge, especially when you have that cervical lordosis. That can be a huge risk for when it comes for extubation too. So just to mention those things.
Thank you.
Yeah, and you can, no, I think you might have something better to add.
I was just going to, I know we talked a little bit, but just for everybody, I think from a prehab and rehab standpoint, as far as like if we have magic rods and then the transition from magic rods to a full spinal fusion, depending on where they anchor, is not really going to change function a whole lot. And so if we already have the magic rods in, we've already kind of adjusted to that kind of static posture of the spine. So there's not that huge of a difference. However, because it is a pretty invasive surgery, getting your child like as strong as possible beforehand, and then getting them moving and getting them active as quickly as possible afterwards is going to be a big target, as long as it's like safe and within pain tolerance and things.
I guess we can broaden this a little bit more too, just in terms of like prehab and rehab too, but in the prep going into it, I'm sure you guys did this too, but using cough assists like 4 times a day, making sure the airways are nice and clean going into the procedure. And also, it's not just what's up top, but I mentioned pooping helps you breathe, right? So making sure your bowels are pretty well cleaned out too going into it, because that if your belly is full, then your diaphragm can't contract as well. And while with LAMA2, it's not like, so those with collagen 6, LMNA, and Selenon can have like pretty profound diaphragm weakness. It's less, you can still have diaphragm weakness with LAMA2, but it's more in proportion to the weakness otherwise, right? And so perhaps the bowel clean out isn't quite as paramount and important, but still it's going to help outcomes much better if you're nice and clean down below when it comes time for extubation. And then once you're extubated, if you're on support at nighttime, I would absolutely be extubating to BiPAP. And we always say, extubate from full invasive care or support to full non-invasive support. And that means that teams in the ICUs will often want to do what's called CPAP pressure support trials, which is where it's a setting that the patient will get a breath when they breathe in. They'll get a bigger pressure when they breathe in, and then they have a background pressure when they're breathing out. But it's not attached to a rate typically, which means there's not necessarily an I time. And so, in the I time being inhalation time. Many of the other settings, other modes, guarantee an I time, which is really important. With CPAP pressure support, it's sort of a challenge in itself. If you already have some muscle weakness, to take a breath and like try to maintain the length of it when you're sick can be really tough. And with new hardware and new respiratory mechanics too, because if you're tilted like this, I love it, she's great. If you're tilted a bit, one side of the chest is going to be very tight, right? And one side is going to be a little bit stretched out. Well, once you straighten up, the side that was tight all of a sudden is now stretched, and the side that was spaced out more is now lax and loose. And so your mechanics are different too. And so you really need to go from a mode, CPAP pressure support is sort of a challenge state in and of itself, and we really never do it, honestly. You should really just extubate from full invasive support with a good I time to full non-invasive support with an I time. And for that matter, airway clearance is super important as well, clearly. And so being pretty aggressive every 4 hours, something like that, I'm sure you guys had experienced that. But when it comes time to try to window off of support, we don't window to one nasal cannula, no. If you need oxygen, you need to be on positive pressure, just hands down. Some teams will actually do windows to even maybe CPAP pressure support, which to me, it's like, if you're doing that, you're not there yet. And so you need to do windows to room air, basically. And some programs have done windows to like high flow nasal cannula. And that doesn't offer anything. So it's really like full support. And then once you get into windows, it's full support to no support, basically. And full support to no support. You gradually lengthen the duration of those windows with no support over time.
Do you mind, Molly and Anthony, mentioning what your team did locally for the coming off of the intubation to BiPAP after the surgery? Just for sharing, if it's okay.
Yeah, not at all. So first of all, there was a ton of prep going into this, of course, and a lot of talk in the ICU with that team around exactly that, extubating to BiPAP. We chose, I don't know if this was ideal looking back, but it worked out for us in that when he was ready, when we felt he was ready, he woke up. You could tell he was alert. His color in his skin kind of came back. You could just tell he was getting back to his normal self. He was still intubated at the time. And it was 8 o'clock. I think the night shift had come in, and we were kind of told, you probably don't want to do that. We can. We have the skills, the expertise, but there aren't as many resources to extubate right now. So if something were to go wrong, heaven forbid, just know that the hospital wasn't as staffed as they would be, let's say, the beginning of the next shift. So we spoke. James was like pleading with us to get to extubate him, and we made the decision to do that. And one of the most intense sort of moments of certainly my life. I don't know if they would normally have let us be in the room at the time. We just happened to be there. But anyways, we extubated to BiPAP. He was on BiPAP, I think, for the remainder of his time in the ICU, maybe less that last day or so. But he got back, and at the end of the day, it was the right thing to do. James was ready. He slept soundly that night as well as he could, understanding the circumstances. But that took, 90 seconds for that to happen, right? Extubate, get him to BiPAP, and then kind of recover. We probably spoke for, hours leading up to that on this plan. And with all things considered, Molly and I just made the decision it was the right time, understanding the staffing and everything else. And again, it was the right thing to do at the time. But we felt comfortable doing that because of the prep work that we did ahead of time, and the questions that we were able to ask, and the guidance from Reghan and others. So is that what you were looking for? Correct. That's right. That's exactly right. His own breathing was naturally sort of breathing over the settings of the BiPAP, right? Which or of the
that invasive ventilator.
The invasive ventilator. That's right. So again, just another sign that we all recognized to say he was ready, and time it aside, it was the right thing.
For sure. Thank you for sharing that experience. But talking about extubation, it's really important to know, can you reintubate, right? And so for some of the airways, especially with LAMA2, like as you go down the road more with the contractures of the mouth, the open bite, you can't visualize the chords at all. So we've had some patients in their like 20s, and I think, how old was she? I think mid-late 20s, and she needed her wisdom teeth out actually because they were causing issues. And so you can fiber optically intubate, so we can help with that in pulmonary too. And somewhat with anesthesia, more or less, or ENT absolutely could help too. But you need to be if you have a known difficult airway, you need to have a team ready to reintubate if you need to over a scope. Don't putz around, just do it. And really, you can intubate fiber optically essentially anybody. It's a pretty rare scenario where you can't do that. But just to mention.
Hi, my name is Zeke Rodriguez. This is my wife, Yessie, and Emma. We're really new to this whole thing. We just got our diagnosis back in May, and I guess my question is, what questions should we be asking that maybe we're not already? We're kind of limited. We're based in the El Paso, Texas area between like Chihuahua, Mexico, and El Paso, and in terms of like specialty care in our area, we're very limited. So we're kind of doing what we can with physical therapy 4 to 5 times a week. My wife is doing a really great job with that. We're going to be going to Cook's pretty soon on the 15th, actually, for our first appointment there with neuro as well. But apart from that, I'm just kind of curious, like, what questions should we be asking? What are some of the things that we should be doing? And really good to meet you in person as well.
So maybe I'll take a first crack at this one. First of all, she's beautiful. We've been like visiting here a little bit, and she was offering her comments on the previous discussion. So one of the things I always say first is that she is a child with LAMA2. She is not a LAMA2 child. So the celebrating like all aspects of development, and it is recommended that the full developmental assessment take place. Language, social, fine motor. The vast majority of children do very well with language, social, and fine motor, so do be saving for college. That would be the first bit of advice I would give you at visit number 1. But the other thing to know is that this is, for me, this is a time of great hope. I say all of those first things, even if there were no treatments anywhere around the corner. I do think being at a center where they've seen some children with LAMA2 is very helpful. And there are, right now, I and people around the country are leading kind of what used to be called a natural history study, but it's really an outcomes. Because when you've met one child, one age, that doesn't mean the next child looks exactly like your Emma. And so knowing where each child is in terms of their strength, their function, is really important. And I'm going to pass it to my colleague to the left to talk a little bit more about function. But I think the most important thing to remember is that she is a beautiful little girl who happens to have LAMA2.
Yeah, I would absolutely agree with everything that Anne said. I think doing a full kind of developmental profile of your daughter and just seeing kind of like how she's doing and as far as meeting motor milestones, but also, again, like fine motor, language, things like that. And then if you have access to a multidisciplinary clinic, I think that's really important. If, depending on where she is functionally or developmentally, sometimes we can help give recommendations about equipment that can be really helpful to support her in her development in other places, and also working with OT and making sure that she's able to communicate what she wants to and participate in
I had one thing
yes,
to.
and sorry.
So I had one thing to add as well. Like I have a 10, very soon to be 11-year-old daughter who has LAMA2. I attended my first conference here. This is our fourth, and my daughter was close to that age. I think she was about 2 at the time. And we live in a very remote area of Oregon where we don't have any medical specialty that has ever seen a kid with LAMA2. Ironically, there's actually one other kid with LAMA2 in our town. I don't know how that happened, but 2 kids in a town of 100,000 people with LAMA2. But for us, like, these conferences have been invaluable because we get to meet like specialty and people who have seen numerous kids, like the people in front of you, and having the comfort of like knowing who they are, maybe grabbing some email addresses, like having letters, having the stuff that's provided on the QSCMD website about guidance. We've pretty much had to train our doctors and our PTs, and we found a pediatrician who just kind of said yes to whatever we told them and signed whatever was needed for insurance or whatever else. And then we have to travel a few hours to go and find a good hospital where we can get the care of a hospital that's actually seen kids before that have had LAMA2 or anything similar. Happy to talk to you guys all day. Yeah.
Yes. I did have one more note, and it's about early power mobility as well. Is that early exploration and self-driven exploration is a really important part of development and overall development. So even if she's having difficulty moving on her own, there's plenty of options for young children who can get in a like a scooter or a power chair or something to that effect, that would make her allowed and able to explore her environment on her own. And so that is also a very important part, I think, of development.
Can I just add one thing? And by the way, I'm dangerous with the microphone. I have
No way.
So the last bullet up there, the care guidelines, right? If you haven't gone to the CureCMD website and looked at those care guides, there is a project right now to kind of update them, revamp them, and sort of modernize them, so to speak. And in the ICU, actually, when James had his surgery, we printed some off and we gave them the care guidelines that was published on the LAMA2 site. There is a wealth of incredible information in there, and in Mark's case, and maybe yours and many others, where you don't have that specialty locally. That's part of the answer, right? It's a multi-leveled answer, certainly, but those care guidelines are part of the answer. So if you haven't at least pulled them down, read them, just know that they're there, and know that I think most doctors, PTs, OTs, medical professionals are receptive to the guidance there, especially when they come across something that they might not be familiar with.
And if you're on Facebook, the Facebook groups are amazing. There's like a ton of mums and dads there that ask any question that's probably been asked before, and they'll dig up the question and share the answers, and it's amazing.
I completely agree with everyone, but I just want to say that from my personal experience, I nowadays see around 120 patients with LAMA2 in Brazil. That's a lot of patients. And the major point of morbid mortality in those patients is the pulmonary care. So I think it's really super important to be aware when to use the BiPAP, to always have a cough assist because the cough is not strong enough, and then perhaps just the flu is going to be a big issue. And nowadays, I have to also remind those patients that we have to get the vaccines to avoid most of the pulmonary infections that we can. So I think that if you have to find strength on one thing first to fight for, that would be the pulmonary care, in my opinion.
I guess I'm biased, but fully agree. The one thing I would say too, though, is like irrespective of the importance of pulmonary as well, but I have a really low threshold for doing sleep studies in children with CMD, more or less regardless of the type. But sleep apnea or sort of compensatory hypoventilation, we call it, it might look totally fine, but if you look sort of under that stone, they could just be breathing faster to try to exchange gas appropriately. But I have a very low threshold, at least for a baseline. A normal study is still valuable, right? And so it's not uncommon that we'll see patients with LAMA2 for the first time in clinic, and we'll just get a sleep study. Even though, yeah, sure, there's no snoring, there's no pausing, gasping, more or less sleeping through the night. It's sort of reassuring stuff. But I know that the chest wall mechanics, again, the diaphragm's not as effective as some of the others. Oh, sorry. There we go. Thanks. I'm dangerous with the microphone too, I guess. But the muscles between the ribs can be disproportionately affected with LAMA2, right? Yeah. So I have, again, low threshold. So your first meeting, you'll see what they say, but I think it's a fair question to ask, should we do a sleep study and see? Because that is where disordered breathing happens first. Before it reaches daytime, and hopefully it never reaches daytime, it's going to happen at night. Night is a challenge state for us. Or it's a restorative state for us, sorry, but when you have some muscle weakness, it's a challenge state when you're sleeping.
Just a quick follow-up question with that. So when she was born, they originally thought she had like bilateral club foot. Because of that, she had like the incision, and to like correct it, she still has the Ponseti boots that we put on her at night. I mean, sometimes like we feel like that's one of the things that causes her to not really sleep well at night, and she complains, kind of angle it up a little bit so like she's a little bit more comfortable, but there comes a point too at night when we're just like, okay, we just got to take these things off, like to be very honest. Just kind of curious if you have seen that, if that's something that can also affect.
It's really tough. Yeah. So with the braces on at nighttime, that can impact sleep too. So it's hard to say, is it breathing or is it something else, right? I think knowing what we know, you wouldn't be wrong with, she's awesome. You wouldn't be wrong with, I know. Stealing the show, right? That's awesome. I think it's tough to sort out, to answer your question. And I think that if there are you could also have some guidance of, if she's little, so she's going to sleep a lot, right? But is it sort of an atypical duration? Are her naps really long? Is she just wanting to sleep all the time? Is she really irritable when she wakes up? There may be other signs that she's having a hard time when she's sleeping at night. Again, the braces could be muddying the waters, but.
Yeah, the braces can be on anytime. So the first thing I tell most children who don't want to wear them at night, which is to say that I say this to most children, because no child really enjoys them at night, is that they can have them during the day. 6 hours is considered sort of the minimum whereby they might keep the feet at that correct angle. So you can de-guilt yourself and take them off at night, in my opinion. And I will pass it to you.
I think we're in agreement, Anne.
Shockingly.
Yeah.
She probably taught me that.
Sleep is very important, and so if her braces are not working well with her at night, and it's causing disruptions of sleep, if it's causing, stress within the family, then absolutely wearing them during the day is fine.
Okay, hi, I'm Courtney. I left my name tag in my son's pouch, but I have 2 boys with LAMA2. They're almost 19 and 22. And I feel like I've learned a lot just in the last 2 hours that I didn't know. I mean, they both gone through the youngest one had the magic rods and then a full spinal fusion. The oldest one had a spinal fusion. I don't remember them getting any positive pressure, only oxygen for all of their surgeries. So that's like, oh gosh. Even my Cody, the youngest one, they talked about it in a young adult session. He was like, I've never gotten that. And I was like, I know you haven't. But one of my questions, so as they're transitioning into this adulthood, Cody just went on BiPAP probably 2 years ago at night. Caden's still, they've just suggested it, and he's 22. So we are now, but they're now 18 and 22, and they're like, I sleep fine at night. I don't need that. And Caden's probably my more stubborn one with that. Cody's like, okay, I need it. They actually present semi-differently. One is not very rigid. He can bear a little and shuffle weight with me. He has his whole life. And then my youngest one is super contracted, so he has never bared any weight. So I don't know if he struggles more pulmonary with that. He struggles when he's had pneumonia multiple times, where the older one doesn't get it a whole ton. But I just, as I'm listening to everybody, seems to be on BiPAP way earlier than they have. And I don't know if it's just because the team that we work with isn't as progressive, or we just were at neuromuscular clinic, and it's what? Yeah, their diagnosis is myrisin deficient.
Did they ever attain the ability to walk independently?
No.
No, okay.
They've always been in chairs.
Okay.
So they are, when Caden was first diagnosed, we didn't even know LAMA2 yet, so it was just myrisin deficient based on their muscle biopsy. So
during their lifetime, because you said 19 and
22.
Yeah, so the gene was known when they were born, but not the knowledge. And so when we did a retrospective study, Dr. Orbach and our team, looking internationally at patients and looking at what we're doing right now, the difference is knowledge. So
they didn't even talk about it. They just called it myrisin deficient.
Exactly.
And then finally they said, oh, we know the gene now, so we're going to test you, do gene therapy. So then that's when they told us that's our team. Our team.
So now we're proactive, not reactive. We don't wait for pneumonia. We know we should be ahead of the curve, get the BiPAP before the child has pneumonia or has an urgent hospitalization. So that's the main change. It's never too early to start BiPAP. One little caveat in the little ones is when they're small and the tongue is large, some of the early sleep studies are read as obstructive, and they probably are, but then it always goes on to be a restrictive pattern. So we know that some kids do start BiPAP early. It's never too early. The bigger risk is waiting too long. So thankfully they're on it now.
Yeah,
I'm going to keep passing them.
We're on the path.
So
the older one is still.
One more adult thing that it should clearly be done is careful cardiac monitoring.
We did have echoes and Holters recently. So
okay, good.
Yeah.
Nice. So I completely agree. I think BiPAP or non-invasive support, we probably should think of it more as like non-invasive ventilation, right? It's sort of what we're. But
just to be clear, so I'm trying to make it very digestible. Never say yes to CPAP. So BiPAP is your buddy, because B for BiPAP, B for buddy. It's very important. But it is the trade name. But that's why I say BiPAP. But bilevel is the real generic terminology.
Okay.
It's all good. I just the nuances, I suppose, semantics maybe. But so Did you say one or both are on? One is
the
on?
The younger one is on BiPAP. The older one, now they just did a sleep study and they said yes, so we're now going to have another sleep study for his
for the
settings.
titration, for the settings?
Mm-hmm.
Okay, good. I think that part of it is knowledge is power, absolutely. We know more now, definitely. And there's also, not every center is the same. So a lot of sleep labs, it's sort of more looking for that OSA picture, right? Obstructive sleep apnea, which we know there's obstructive sleep apnea, and then there's sort of neuromuscular obstructive sleep apnea, and then there's hypoventilation. Pulmonary function testing can sort of guide you on when you might need to consider non-invasive ventilation. But honestly, the main study that's sort of quoted for that, if you wait until that point, sort of the ship has sailed.
Okay.
And it could arguably be started much, much sooner than that. And so I'm glad to hear that they're going to be on it.
They are.
And when you're reading the sleep study again, it's like I maybe put my foot in my mouth, but I wouldn't be surprised if the earlier sleep studies showed maybe some fragmentation, decreased REM, higher respiratory rates that would have improved with BiPAP. Yep.
One fun thing I tell my young teenagers, young adults, and they're pretty logical this way, is try it and sort of analyze logically, how you feel the next day, how rested you feel. There can be little signs that they don't even appreciate: anxiety, headache, not the classic morning headache necessarily, but just a little bit not quite as good at the end of the day, and so and if they have sort of an easy way to measure that themselves. I always say a very, very simple journal. Nothing like, right, fine day was, it's a 0, 1, 2 with me. There's no higher scale. So 0, everything was fine the next day. 1, I did get tired in the afternoon, or I noticed something. And 2 is, no, I was really tired. And then if they have that information and then they're trying it, they'll probably see a pretty striking difference in those
feelings. I mean, he felt that right away. It's a little of a double-edged sword, right? Because he doesn't love the mask and the machine itself. Is there any advancements in that?
Yes. Can we fix that? I don't know. Maybe. That's what. Hey, Mark, come on up. So there are many mask types, and even the nasal mask, right? Which we
did kind of switch to a nasal mask, and he seems to like that a little bit better. Okay. Than the whole mouth thing. So
yeah, good. So we definitely try to shy away. And actually, the titration's coming up. So I would not do the mouth and the nose mask. I wouldn't do a full face. So only do the nose.
Okay.
Because if he throws up in the middle of the night into a full face mask, he's going to aspirate, right? Okay. And so we always go for nasal. But even so, there's different types of nasal masks some are more comfortable than others. Like around the nose, little prongs in the nose. Some people love them. I don't know how they do, but they do. And then there's some that just rest underneath but hook up on top of the head. And so there's many types to try.
Maybe we can do that.
Yep. But I totally agree. You don't know what you don't know unless you try it, right? We are in our bodies every day, and this is how we feel. I'm glad he feels good because he's probably pretty resilient then. But he might feel 100 times better if he's on support at night. So.
And then I just want to say a comment to you guys over there. Just keep living life. They're both in college, doing super well. They're super intelligent. So just keep living life. They navigate UW-Milwaukee and Wisconsin all by themselves, and they're rocking it. So
that's nice. I also want to add, I don't know if that's something that happens here in the U.S., but in Brazil we have this fake news that BiPAP is going to make your lungs or your muscles lazy, and that's why you should wait as long as you can to use it, because otherwise it's just going to make it worse, and that's not true. I don't know if you ever heard that, but I hear it a lot, and it's not true.
I was just going to make a comment about the BiPAP masks. So our son has been on it for 7 years, and basically I just wanted to point out that he actually has a cradle, and then he has a different one that's a cushion. And we switch back and forth because we've learned a couple things. First of all, like when he needs to be on it more when he's sick, he gets skin breakdown, so it's nice to have two different ones that you go back and forth between. But in addition to that, what we learned some of our admissions is that there's a part that goes into the interface for the cushion, and not the cradle, but the cushion, that you can run the nebulizer through it. So it's really helpful, like when he's sick, because then you don't have to take him off of BiPAP in the middle of the night to do a neb treatment. So I wish that I would have known some of that 7 years ago. So
Nice. That's huge. Yeah.
And I have a question. Do we know how many people that are estimated to have LAMA2 now?
So I can. So this, it's funny, as a deep dive to do a natural history study, you have to try to figure out both the incidence and the prevalence in an area, in a population. So this is rare, and I can give you an idea. I think the best idea I can have. I worked for 30 years in an area that had a catchment of about 2.5 million. And in that catchment, 2.5 million, over 30 years, I diagnosed one about every 3 years. So in the United States, we believe that right now, as well, I know for sure, under the age of 5, there are at least 30, there's 25 identified, but mathematically there's another a few out there under the age of 5. And we think we underestimate, incidence, prevalence, or how many are living with LAMA2. That increases every year, and I would say that increases every year because of excellent pulmonary care. So I think my oldest patient, 45, who got excellent pulmonary care starting very, very, very young at Washington University. So and so I do think that how often it happens, it's about that. Like a doctor like me who's at a big medical center, another big medical center, still about one every 2 to 3 years for LAMA2.
So Makolek is he'll be here actually on Sunday. He is a biostatistician, and amongst other things, and he and the Broad Institute have a massive database of just genomes around the world of not affected, just humans. And their calculation was what there should be based on population is 1 in 387,000, I think, was the number. So ultra rare, but not as ultra rare as some of our other CMDs. Some of those are like 1 in 900,000. So.
But the good news there is from the regulatory agency standpoint, so FDA and European Medical Agency, it's ultra rare. So it's an orphan disease, which means it's incentivized for companies and to invest in the therapies and development. So it's a high unmet therapeutic need. So that's the silver lining for an ultra rare orphan disease.
Yeah. I hate microphones. Just the numbers that you were mentioning, is that full deficiency and partial deficiency? Or is that just...
The vast majority have full deficiency. So it's about 18 to 19 out of 20 have full deficiency. But the point is valid that we may be missing some of the partially. The age at diagnosis, and this is also in a huge population, that retrospective study that I did years ago, virtually every completely deficient child in the United States is diagnosed before the age of 6 months, and now. We think that's late, and the 5 states now that are either going to start newborn screening or have already for Duchenne, and at least in Ohio, one of those states, the upside of that for other muscular dystrophies is that they too will be recognized. So if your catch is the CK, these particular forms of muscular dystrophy do have an elevated CK, so they will be caught. So we think 6 months is a late diagnosis, but we may not move that needle until there's newborn screening.
Historical fact for your patient Anne, who's 45 years old, when that patient was born, no one knew the gene for this. So we only define muscular dystrophy as Marison positive, Marison negative. They hadn't discovered the gene. So having a diagnosis as now as possible at such a young age is rapidly changing quality of life and health. And so we're in a different place in space. So we know patients actually in their 50s, but many of the ones who may be still alive or older were never diagnosed genetically. And one last comment is, right now, currently, we have colleagues in certain parts of Europe, actually the UK, where Genomics England will not report a diagnosis of LAMA2 muscular dystrophy if only one variant is found. It's very common to have only one variant in LAMA2, but still have LAMA2 muscular dystrophy. So again, undercalling is probably very common, underestimating the prevalence.
Pivot back to non-invasive support, just a little troubleshooting tidbit in case it happens. Did I hear you say you're from Wisconsin? Okay, it really goes for anybody, but when sometimes patients feel like they get rain out, being like tons of humidity on their nose, or it can happen with the trachs, yeah, exactly. So that has to do, you can adjust the humidity settings of it, and okay, and then what it has to do with is sort of, if you think about it, the temperature and the humidity in the tube, it's warm, right? It needs to be. And whatever it is on the outside of it impacts the air that's immediately on the inside of the tubing. And so if it's warm inside, but it's cold outside, or if there's a fan on, it can cool it down such that you get condensation buildup, and that's when rainout happens. So what you can, yes, so you can actually, and I think they're on Amazon too, or you can make it, you can get like a sleeve or a sock to go in the tubing to provide like an insulation barrier, and it can help prevent that rainout from happening. Because we don't want any drinks of the, the humidity, so yeah, yep.
Got a question over here.
Hi, my name is Karen. I'm from New York. My daughter Orla is 18 months old, and she was diagnosed last year with LAMA2. I just have a question about the cough assist. So we were given the cough assist, and we were told to use it when she's sick, but now that I'm hearing so much about pulmonary health and being proactive, I'm wondering if I should be using that with her every day.
It's not going to hurt to, and honestly, it's going to help her behaviorally sort of get used to it as well. It'll provide the stretch of the chest wall, which is important in maintaining the flexibility of that joint. We have to remember our spine and the ribs form a joint, right? And they undergo a range of motion that if you don't do that, it ends up getting sort of restricted. And so the benefits are going to be that you get that exercise of her chest wall and the stretch of her chest wall, and then you can, of course, help clear her airway, but importantly, like behaviorally, she's going to know what it feels like and hopefully accept it. She probably doesn't like it initially, right? But yeah, but then when the time comes when she's sick, you're not going to think twice about it. You won't say like, oh, how do I do this again, right? And then she'll be more accepting of it. So I'm always sort of a proponent of probably daily at least would be good to try.
And you think like more than once a day, or like morning, night?
I think if she's well, I think just once a day would be fine.
And then just the one session of the 5?
Yeah, that'd be fine, I would say.
Great, thank you.
Mm-hmm. About that. So my sons were actually in the study at Cincinnati Children's Hospital, like almost 10 years ago now, maybe.
Yeah, thanks for doing that.
2016. But then after that, we kind of it just ended. And then I have a cough assist, but I only use it when they're sick.
Okay.
So, and I always thought about that, and I asked our pulmonologists about it, and they're fine. Their pulmonary function is fine. That was kind of the response. And I love our pulmonologist, so I don't want to, but I don't know, it was like.
I think, so with that study, we ended up, so what the study was we employed hyperinflation, right? So it was just the in, and for a little bit longer duration to get the stretch. And we tried doing it 15 minutes twice a day.
Yep.
Importantly, we tracked, and it's a lot, right? There's already a lot on your docket to try to accomplish in the day. And so it's admittedly a lot to ask for.
Yeah.
And we tracked adherence as well, which is a really important piece. And we found adherence to be about, I think, like 50% roughly of the time. And so we did end up seeing a signal. We were sort of tracking pulmonary function testing as well. And and there did seem to be a slight signal in the change in forced vital capacity there. And importantly, though, a lot of the kids already had sort of moderate, severe restrictive lung disease on it. So it makes you wonder if we had employed it earlier, would that have shown a little bit different signal too, right? Improved signal. But what we found was that when you get that stretch in, your chest wall is more compliant for a period of time afterwards. Honestly, it's not a super long-term effect, but if you're doing it on a daily basis, that can absolutely be helpful. And there's other papers showing that there can be some effect too. I think I respect what you're saying
Should I talk
with
to
the relationship.
my pulmonologist about it again?
You could. At the same time, I think you could also just, I don't know. Sometimes my patients will come and they say, yeah, we did this. I'm like, okay, that's all right. It's not hurting anything, right?
Sure.
And so I think it's not going to hurt anything. The other cool part about this study is there was not just the adherence and some of the other numbers with forced vital capacity, but the more qualitative feedback of, hey, my kid was able to blow out birthday candles for the first time because you were you get a good breath in and more easily. So your respiratory system, your breathing is more efficient when your chest wall moves more easily, right?
Yeah.
So you can get bigger volume. So
I mean, they do have good pulmonary function tests still. Like and they're pretty static. They don't change a whole ton. So.
Good.
Yeah.
It's not going to hurt to do though, I think.
Yeah. So thanks for sparking that.
I'm sorry, just one more question on the same topic. Is it better to do the cough assist when they're sitting or laying down?
Good question. Sitting is going to be a little more effective, I would do. So some patients will do either, but when you sit up, you're going to, the one thing is, so we have to think about gravity, right? And so when we sit up, our abdominal contents pull the diaphragm down. You actually have bigger lung volumes by sitting up. And just laying down, even in neurotypical individuals with regular strength, our lung volumes go down when we lay down at night because your belly contents are being pushed up against your diaphragm. So the system is going to be more sort of, optimized in the sitting position, and you're going to get a bigger volume as well in the sitting position. So I would do that. Yep.
Hi there, I'm Ashley. I have a son who's 6 years old with LAMA2 muscular dystrophy. And I thought I could say it without crying. These are happy tears because I'm just so happy to meet all these people in person and that you guys are here. It really does mean a lot. Dr. Foley's seen me cry before, so it's all good. To speak to the young kiddos and their families, we started using cough assist with Carter at 2.5 months. We had a pretty progressive pulmonologist at Yale who was like, you just got to do it. And so we did it, and I held my little tiny baby, and he's does it twice a day now, and has absolutely no problems with it whatsoever. So there's that. I guess my question is sleep, which is probably why I'm so easily emotional. We don't get a lot of it. So Carter's had probably 5 sleep studies in his 6-year life. One was at 1.5 weeks of age when his CK level was found to be high. I have twins, so I'm also a physician, and I could tell one son had low tone, and I was like, something's up. They hospitalized him, did a spinal tap, all the things, and one neurologist was like, let's do a CK, and he handed me a pamphlet of all the dystrophies and scary things and said, wait 6 weeks for genetics, so that was a pretty tough time in life. And these sleep studies, he wears a BiPAP at night. We just had the settings upped a little bit, and he needs to be assisted at least 3 times a night, if not 3 times an hour. And I feel like you guys were mentioning, maybe an EEG. He's had one during the day, a quick, brief one, just because I was neurotic. And I was like, is he having absent seizures? I don't know. Is there anything more that I could do? We have a blow-up mattress. We have his room super cold. We've got all the settings. I've literally, probably everybody's seen my name on the LAMA2 site 100 times, like, SOS, does anybody sleep? So tough times in our house. So, I'm open to any thoughts. Like, am I missing something? I can tell when he doesn't sleep well. I mean, if I feel this way, I know he's going to be more grumpy and grouchy and, not going to feed as well. So any advice would be helpful.
Passing the mic to the sleep expert. I'm going to quickly excuse myself and give Dr. Rotem Orbach the seat. I need to pop over to college in 6th session, but I'm leaving in your very capable hands, Dr. Pascoe.
Thank you for being here and sharing that too. And that I feel for you because that's really, really, really tough. Sleep is incredibly important. And I guess I'm glad to hear the settings were recently looked at because I think looking at downloads, perhaps the settings could be tweaked a little bit. One thing could be just sort of trying to think outside the box on the spot too, which is totally fine. That's why we're here. I wonder about leak, right? So if there's an issue with mask leak, if he sort of moves around at night at all, then it doesn't take a whole lot to, break the seal somewhat, and air is blowing into his eyes. May not like that. So that's where some of the different mask types might help out. A lot of the masks we start with is a nasal wisp that goes around. It connects here, so it's fun. They call it the giraffe, right, for the little kids. But if you're moving a lot, if you can imagine, if you turn your head and your hose is here, then it's going to break the seal. It's going to leak, and that could cause an arousal potentially. And so that's where trying other mask types might help. So the ones that connect up here will move with you when you're moving around, and so you don't have the leak issue as much.
That's a fair point. I do think it is much louder now that the settings are changed, and I'm kind of like, the machine will prompt me that if there's too much leak, but I'm like, I can feel, I sleep next to him, especially this past couple nights, and there's a lot of air coming out, so I feel like that's probably a valid piece.
Because there's intentionally a valve so that air does come out, so that way CO2 can escape, right? But if you've noticed that change, then perhaps, and we can talk more too after this. But the other thing to think about, what Dr. Sinani mentioned, is ferritin levels, iron levels. So in sleep, we target a ferritin of like 50 in kids. Honestly, I have some patients where 75 is even better. Really important to be checking it not around any infections because it can be falsely elevated, as you know. And so giving at least like 3-4 weeks from an infection. You don't need to be anemic to need iron. And it's probably 9.5 times out of 10 when we're checking ferritin levels, we're starting on iron. And iron, the other thing, side effects, GI upset, constipation, right? Not cool, especially in this population. So there are such things as IV iron infusions, which can go a long way. I think there's more to iron than we know in sleep, and perhaps my neurology colleagues can expound more on that. But we know it's involved with restlessness, but I definitely have seen some kids who aren't necessarily super restless, but their iron was low enough. You get them on iron, and they actually are sleeping immensely better. And so I think there's more to iron than we realize. So I would say if he's on good support, think about the mask maybe for leak, and then looking into iron would be another step. If all is well otherwise, I'll do some medication sometimes for kids too to help them stay asleep.
That's valuable, thank you. And I was just going to say, my boys just met Cody and Caden. Carter was so excited to be like, Mom, they have LAMA2. So if they need to chat with Carter about getting on a BiPAP, he'd be happy.
I did think your adult children had good judgment in sneaking on out of here. But I wanted to say one thing about sleep. First of all, there's one thing everybody in the room should try to do. Bend your neck all the way down and try to breathe in. It doesn't work well. Tip your head all the way back. Try to breathe. It doesn't do well. And so just the alignment of the neck, it's a simple thing. I'm sure your pulmonologist told you that, but occasionally they forget to tell you that. Second thing, just to remember your child's a child. And the time they go to sleep, you're a doc, so try to keep it the same every night. Try to keep the routine the same. But I would also submit that some children are either morning doves or night owls from the day they were born. And that fact means that exactly when you start this odyssey of getting the, perfect 12 hours for a 2-year-old or a 6-year-old, the amount they are going to sleep may not be 10 hours, or it may not be 8. It may, so sort of recognizing that part of the picture, how much does this child actually need? Because I have seen children with LAMA2 and with every other type of muscular dystrophy who biologically need more or biologically need less.
I had just a really quick question on that. And apologies if this is a little bit of a silly question. We've just noticed with Emma, like she's been able to eat really well. Like she doesn't have like any respiratory issues. Pulmonology kind of like gave her the thumbs up. Like everything is going well. We're seeing them. Is that something that like can be progressive? Like with time, like should we expect to see that, like where we would need the cough assist and like the BPAP and things of that nature?
I would think it's certainly something to have on the radar. I think that she'll need to have some sleep studies as time goes on. If not, like I said, if not in the nearer future, I just have a very low threshold for it. But go ahead.
Can Emma put her arms all the way above her head?
Not all the way up, but she can bring it up to about here.
Yeah, so that a simple movement corresponds very well with pulmonary function. So the strength of your upper shoulders corresponds very well to your pulmonary function. It's hard to do pulmonary function in an 18-month-old. So it is absolutely something that should be monitored. Yes.
Yeah. And with the cough assist, has she had colds or infections?
She has. We do a nebulizer, like when she has like just allergies. We live in the desert, so there's just a lot of dust and things like that. So it's not uncommon for her to do that. But she's only been sick like twice, really, where we've had to use the nebulizer, and it's helped tremendously.
Okay, good. I think the message is being really proactive and not reactive, right? So I think it's not unreasonable to consider like cough assist should she need it, right? It can absolutely keep kids out of the hospital too. So I think it may well be in the future, especially that. Thank you for asking that, because that's very true. Yeah.
I would also just say just get the equipment. Like, if you don't live close to a hospital that has it or an ER that has it, just get it. Like, if insurance is going to give it to you, just get it. Right? Like, don't wait hoping that you've got a superhero of a LAMA2 kid. If you do, fantastic, that's great. But like, have it on hand, because in a pinch, it's really helpful to have it quickly. Yeah.
Hi, my name is Sam. My son's name is Morgan, and he's about to be 10 in September. And my question has to do with hypoglycemia. He has a history of having episodes. We've been to the ER a lot, and they didn't know a reason until we spoke with a endocrinologist, and she started thinking, hey, because they tend to happen in the morning. And she said because of his low muscle tone that they think, her opinion was that he didn't have anything to pull from in the middle of the night. So when he would wake up, he wouldn't have the sugar in his system. And he's been all the way down to like 18 before. So they've had like 7 people in the room and he's a hard stick. Would take him 2 or 3 hours. They would be giving him the jelly, the high sugar jelly. And it's just been a struggle, but we finally got Dexcom. They decided to try Dexcom with him. And for the most part, it helps. Once he gets under 70, 60, that's when we push food. Now, my question is there some way that we can help kind of prevent? Is there more of a way to, like, make him more stable? The last time he was in the ER was in December, but he has had other, like, drops, and we were able to bring him back up. But it's like he was in the ER a couple times a year, and it's just been difficult. So I'm wondering if there's more information. And then my follow-up question, I guess, is we just got results saying that, I'm so sorry, we got results saying that he moderate sleep apnea or obstructive sleep apnea, but he's a mouth breather because he's got the open gap. And with the vomiting, is there an option, a way that we can still use like a BiPAP or something? Like, what do we do, basically?
So you're not alone in that. We have around 10 to 15% of the patients that have hypoglycemia. At first, we thought that was related to the, as you said, low mass of muscle. So that would be relatable for every kind of muscular dystrophy, but it's not true. It's more common in LAMA2 than in other muscular dystrophies. So we're still not sure what happens there, but perhaps it's related to some sort of genes that are downregulated and are related to metabolism. We're still learning about it. But on the practical way, what I can say is that those patients that has low weight, they're at higher risk of that happening. So we have to be sure that those patients are having the best nutritional care as possible. And sometimes we do need to add something to their diet, so it has more calories, especially right before they go to sleep, because that's gonna be the longest time they're gonna be without eating. And then at the morning, they have a higher chance of having hypoglycemia. And that's also true when they have some sort of infection, because then they're gonna use more of their energy, and that includes the muscle energy, and that's a risk for hypoglycemia. So we have to prevent the situations that causes a lot of wasting. That's infections. That is related also to maintaining the pulmonary function as best as we can and using BiPAP at night, because that also causes a lot of wasting and excess of energy loss. And from we learned, we also need to check the nutritional status of the patient. And sometimes we have to use more than just sugar, but also fat. So we can have a different kind of metabolism. So we sometimes use some supplements of fat to the patient, especially at night. And that seems to be good. Really rarely, the patient has a lot of issues and struggles to eat, and then we might think about a G-tube, but that's rare.
Can I just, I'm sorry, really quickly, you mentioned G-tube. We've had a long history of hypoglycemic issues with our son, 3-4 times a year. We'd be in the hospital 12, 15 times a year, if not more. We'd have an episode, we'd be able to bring him up. He had a G-tube put in before his surgery a couple years ago, doesn't matter. It's almost, I don't think he's had a hypoglycemic episode since. And it makes sense, right? You're fasting overnight. He may have had an early dinner or maybe didn't eat a ton. He had some nutritional problems to begin with, so there was the G-tube was more than just addressing the hypoglycemia, but it totally changed everything for him. We've maybe been hospitalized once since then, if that. But anyway, something to consider. If he's on BiPAP at night, you got to consider, G versus GJ tube, and then also having airway clearance with the BiPAP, but it changed everything for us. So just something to consider. And he does, yeah. And he's only tube fed at night. Throughout the day, he eats by mouth. So no issues there.
And I think about the G-tube, and because the patient's still able to eat by mouth, it's just sometimes the G-tube is good because if the patient's sick, you have a reliable source of feeding as well. So sometimes that really helps.
And then I think you had a question about like with the moderate obstructive sleep apnea, right, and positive pressure for that. So as far as the vomiting goes, with that, obviously can be really scary, right? And that's one reason why we focus on the nasal mask, so that way the mouth is also covered. Would he be able to take the mask off if he were to start throwing up at night? No? Okay. So when you mentioned the G-tube as well, that can be an option because at nighttime, yeah, you might have some feeds running, and probably ideally, we're pretty conservative. Some kids will do okay with feeding through a G a little bit at night and having the nasal mask on, the BiPAP on too, but it can be a little bit nerve-wracking sometimes, right? Because all it takes is one episode of vomiting with the mask on. So we're pretty quick, I would say, to try the GJ approach and do that transpyloric feeding at nighttime, so that way you can have the G venting at night should air be blowing into his belly with this support. But again, nasal mask, not the full face mask, regardless then. And I know some of the congenital muscular dystrophies, you get some gastroparesis too, right? So if the vomiting is related to any just like slow gastric emptying or whatnot, if there's any like GI workup, and perhaps neurology colleagues could comment there, but if there's any prokinetic to try to decrease the vomiting that he has too, maybe that's actually the solution for him. Yeah.
I don't usually see gastroparesis in LAMA2, but still possible. And when I see it, it's really related to painkiller drugs. So sometimes the patients have because of the back or the hip situation. So we have to check that because sometimes you have drugs that are also causing that problem.
I'm dangerous with Mike. She avoids it at all costs.
Yeah. We're a great pair. I just had a question on facial weakness, the enlarged tongue. Our son, his front teeth can't touch. His tongue is a little enlarged. We often will say, Bud, and he almost does tongue exercises to pull his tongue in, and he really works hard at trying to keep the best he can. Are there any pieces of equipment that we should be, like chin straps to help promote at sleep? Well, I don't even know what I'm asking, but is there anything we could or should be doing to help him in that area?
Yeah, one of the striking things about some children with LAMA2 have a very high arch palate, and it isn't necessarily that their tongue is extremely large, but it may be that it's narrow. So many of my patients went through the palate expander, the whole 9 yards of the full orthodontic care. If it makes you feel any better, I have 4 children, and there was 6 episodes of orthodontia. So any child can have this special experience, but it is important, however, to work with an orthodontist who does know this. Does know you can't just. But making room is the most important thing. The occlusion will often be off unless you have this. So orthodontia is, I usually can tell at about age 3 if orthodontia is in their future. But
yeah, I agree. I don't think that we really understand how to improve that right now. But we're trying to understand that first if the tongue is enlarged or the mouth is smaller.
I don't think that it can be both, but
I think it can be both, but I don't think that we are quite there yet to understand what's really happening. So What we're doing right now is performing ultrasound of the tongues of the patients to understand if the tongue is actually enlarged or if the mouth is actually smaller, because that's going to change everything what we're going to suggest the next step to be.
Yeah, no, if the palate is high arched, and probably about 80% of children diagnosed with the congenital form, about 80–90% do have a narrow, high arch palate. It's really just has to do with what the muscles are doing in the face that we don't think that much about. But mild facial weakness is part of LAMA2.
I have a question for you guys, actually. I don't pretend to know anything by any means. So, and it's a rare disease, right? And so, admittedly, yes, I read some of the natural history studies before coming here, consensus guidelines, everything like that. Make sure I don't misspeak. And I think you had a question, Ezekiel, about sort of swallow and aspiration, right? So there's aspiration that you can sense, and you cough, and you know what happens, and then there's silent aspiration. You have no idea it's happening, but you're actually food, liquid, whatever is getting into the airway. I wanted to ask you all, in terms of silent aspiration, do you see that sometimes in LAMA2, I think I was reading, and so at what point do you consider like a video swallow study just to confirm? Because from the aerodigestive literature, like the speech therapy assessment can help look at like the swallow function and maybe sort of predisposition, but it's not necessarily great at identifying actual aspiration. And so that's where you need objective, like a video swallow study.
Yeah, that's a great question. So the majority of children with LAMA2, very, very early in life can have a little trouble, or they didn't suck quite as, there's this little period where maybe they didn't, nose as well, so they ended up using a bottle, and it was a little bit easier. So there's this well-described early infancy history that may or may not be there. And then most children, the vast majority with LAMA2, absolutely develop the ability to safely swallow. Having said that, there are some, and therefore, if they swallow wrong, the sensation that, like if you or I swallow wrong, we all sense it and we cough. And that sensation piece is intact. So they, a 6-year-old who's never had any difficulty at all, and they kind of swallow water the wrong way, they're probably going to cough and they're going to notice it. But there are children, and these are the ones you really have to keep an eye on, who had that early phase of difficulty swallowing, but then seem to be doing better, and nobody really paid attention. And some of those children are silent, so-called silent aspirators. In other words, they ignore that signal that something went, if you will, down the wrong pipe. And so we're doing a natural history of very young children, and we are using history and bedside evaluation, and if there's any red flags there, then a more formal swallow study with the whole 9 yards. But it's probably 9 out of 10 swallow okay in my experience, but I would love to know your numbers on that as well.
Yeah, I think that most patients are able to swallow saliva, and they don't have such a severe dysphagia. So that's not usually a concern. But obviously, if the patient has subsequent pneumonias, then you have to ask yourself, is there something wrong here? And I always check dysphagia in my patients as well. So I think that's an important thing to ask. Sometimes the family is so accustomed to having to take like 40 to 60 minutes in each and every meal that they don't realize that it's actually dysphagia. So we have to check that up actively and see if that's a problem. But most of the patients are going to swallow saliva just as pretty perfectly.
Really quickly, we have 2 minutes left, and then there's a break. Do you have a question, Maria?
So I just wanted to mention, I kind of brought this up in the GI talk, but our son is 8. He was transferred at birth, so it was very clear that something was wrong. He's had more swallow studies than I can possibly tell you he's had, probably like 10 at this point. And every swallow study that he's had, he's never showed that he's actually aspirated. But he's been hospitalized pretty much like 6 times, starting round 1 until he was about 5 or 6. And I had been fighting to try a GJ tube for quite some time, and I was getting a lot of pushback. And he was in the ICU. We were supposed to have an outpatient appointment with GI to talk about GJ. And they're like, no, you're going to wait till he gets better. But a couple different times, he actually had an ND tube put in the hospital to help him recover. And this was one of those times. As soon as they started to try and use his G tube again, I thought he was coming down with another virus. And it wasn't until that instance that they're like, oh, well, we think that he's aspirating. But again, he showed no signs. And the GJ tube has been like literally the biggest life changer for us, because now he's still hospitalized periodically, but instead of like 2-week admissions, it's like 2 days a lot of times. And also a lot of times what would end us up in the hospital was hypoglycemia, because he would start throwing up during an illness, where we don't deal with that at all anymore. If he throws up, it's usually like a GI bug that everybody would be throwing up from. So we do GJ tube feeds, and I was really nervous to make that transition because I thought that he would be like connected to a pump all the time. But in reality, for him, he starts about 8 p.m. and ends about noon. So from noon until bedtime, he's off of the pump. It's been a huge difference for us, pulmonary and GI wise. And it's frustrating because if I didn't go to the LAMA2 and see like one other family that has tried this, like I wouldn't have known to push for this. So I think that there's probably more silent aspirating going on than we even know, because like he was hospitalized so many times and nobody ever brought that up as like the reason why we're in the hospital all the time.
Absolutely, that's a fantastic point. The other point making with the many, many video swallow studies that were reassuring, it's also video swallow studies, it's often, especially with younger kids, it's all right, don't eat anything for a bit, and then we'll start feeding them, right, when they come in. But sometimes the dysphagia doesn't happen until later, like into the meal, right? And so initially the video swallow is a snapshot in time, and if it's that time is like at the onset, when the energy and coordination is reserved and functioning fine, you're not going to catch it. So it's not until like later when the fatigue sets in that you can see some more of that dysphagia and aspiration.
Well, and to add to that though, like he was silently aspirating G2 feeds.
Yeah.
Because like when they had started the G2 feed, that's when I thought he was coming down with another virus in the ICU, but in reality he was aspirating.
He was refluxing the feeds and aspirating that. Yep. Yeah.
I think we're at.
Yeah, I think we need to finish and wrap up. I want to thank you all for your excellent questions, for sharing experience, and of course for the panel, also Dr. Foley at the back. And thank you, we're still here. Please come ask us questions. Feel free.